This video goes over the process of getting an oral appliance made so that you can improve your health. And we'll explore what this tells us about whether the current healthcare system is actually more like sick care than healthcare. I was talking to an acquaintance who's currently in the process of having one made, and it's just more evidence to me that what was published in the Journal of Dental Sleep Medicine that I'm showing on the screen is true. It said it's not rare nowadays to hear physicians choose to recommend no therapy to the asymptomatic apnea patient. And I want to start out by saying that I'm not a doctor and I'm not a dentist, so I don't have a dog in this fight and I don't have a dime invested in this issue. So the process is you have to go to your primary care physician and have a sleep test ordered from a sleep lab. Then you take the sleep test and then you wait to be able to talk to a sleep physician about your test results. In the meantime, if you want to know what your test results are, you can fill out a paper and send an email to the medical records department of the healthcare system records department that's holding the test results, and they'll email you back with the results. So you do this because you want to know what your test results are. Now the results come back saying that the recommended plan of action is a CPAP and that the patient will be seen in 6 to 10 weeks. So keep in mind that the documentation for the sleep test is saying that the recommended plan of action is a CPAP because we're going to circle back to this. But first, let's talk about this 6 to 10 weeks. I just think it's so interesting that the fact that the patient has to wait 6 to 10 weeks to talk to a sleep physician in order to move on to the next step is actually documented. I would like to see the peer-reviewed research papers that show that this extra waiting period of 6 to 10 weeks doesn't have negative consequences. I really would. So after reading the test results, you decide that just as you suspected, in your specific case, being that it's mild, that therefore you feel that the most appropriate treatment for you personally is an oral appliance. But you still have to wait to see your sleep physician so that he can refer you to a sleep medicine dentist. So you go to the sleep physician's office and you find out that your sleep physician is seeing you through a camera and a computer screen since he's physically located in another part of the country. And then when you tell the sleep physician that you'd like to get an oral appliance, the sleep physician tells you that you could do that, or you could just wait and not do anything. Remember the quote from the Journal of Dental Sleep Medicine that's on the screen right now, where it says it's not rare nowadays to hear physicians choose to recommend no therapy to the asymptomatic apnea patients? This is where things start looking quite shady. Remember what the sleep test documentation said? The sleep test documentation recommended a CPAP. So the sleep test documentation recommends a CPAP, and the doctor says that you really don't have to do anything yet. So my point is with this, that they know full well that a CPAP is not appropriate treatment for the situation, but yet they still go on record recommending it on the documentation. I would think that most patients would want to avoid wearing a CPAP if possible, and they know that, but they don't say in the documentation, in view of the situation and the mild case that you have, an oral appliance would be more appropriate. Instead, they basically say to you, you might want to just wait and do nothing until your case is so bad that it would make more sense for you to get a CPAP. And that logic makes no sense when you consider that most people would prefer to avoid having to use a CPAP. My other issue with this is that I believe that this is a risk versus benefit type decision. And I'm not sure that there's evidence to support the concept that the risk of mild sleep apnea is so insignificant that the risk wouldn't justify oral appliance therapy. And it comes across like they're saying that there essentially isn't any risk of adverse consequences of mild sleep apnea. And I'm not sure that the evidence and the science agrees with that. If anyone's aware of a study that shows that mild sleep apnea has no significant adverse consequences, leave it in the comments. I'd be interested in seeing that. I'm not sure that such evidence exists. My other issue with this is that someone who's looking at you through a computer screen shouldn't really have anything to say to you on this matter. To get the entire picture about this matter, someone would have to open up your mouth and look at your teeth and check for wear to see if you're grinding your teeth, and that cannot be done over a computer screen. See, as technology advances, it makes it possible for us to have lower quality healthcare services, because now we go to the doctors and the situation is that the doctor is unable to examine us because he's in another part of the country. Besides the problem of the computer screens, looking at someone's teeth to check for grinding is something that falls more into the area of expertise of a dentist than a doctor anyway. So it would be more accurate for him to say that he really doesn't have the expertise to say anything about whether treatment is necessary, since oral appliance treatment protects the patient's teeth from grinding away, and only after looking at your teeth can someone make a fair assessment of whether treatment would be advantageous in that regard. The final thing I'm going to talk about that shows how shady this process is involves the concept of the sleep physician and the sleep medicine dentist referring to each other in order for you to be able to have an oral appliance made. So you've waited for 6 to 10 weeks to see your sleep physician so that he can do whatever he has to do to allow you to be seen by a sleep medicine dentist. But the sleep physician doesn't give you any sort of document stating that I hereby authorize an American Academy of Dental Sleep Medicine Diplomat to treat you. No, your doctor just sends you away and says to you to get treated if you want to. So you send an email to the local dentist who's qualified as an American Academy of Dental Sleep Medicine Diplomat, and you attach your sleep test documentation to the email, and you only have that because you did the legwork to get it yourself, and you ask the dentist if he'll treat you. The dentist responds that he can treat you because he has a good working relationship with your sleep physician who signed the sleep test documentation. So this raises the question about whether, as soon as the sleep physician signed that sleep test documentation that you sent to him, could you have then requested it and forwarded it to the sleep medicine dentist and got started with treatment right away? Was that signature on the sleep test documentation all that was really required? After all, the sleep test documentation includes a diagnosis from a physician. The process would have been much faster if that's all that was required. So what does this really mean that the sleep physician and the sleep medicine dentist are referring to each other? Presumably the dentist reaches out to the doctor and says, hey, is it okay if I treat this person? And since they have a good working relationship, the doctor says, okay, that's fine. But this raises so many questions. Like, what if they didn't have a good working relationship? And what if the patient hadn't had their follow-up with the sleep physician yet? Would the sleep physician say, no, you can't do that until I have this follow-up with the patient? And I've been trying to research this for years to try to understand what this all means. And I really think that I'm an intelligent enough person that I would understand it if it wasn't really just a confusing thing. And I know I'm not supposed to impute motives, but I just can't help but keep thinking that this is intentionally being made confusing so that patients will just rely on them, since people who are confused are easier to control. My other issue with this process being more drawn out than you would think it would have to be has to do with what the Journal of Sleep Medicine said, that physicians aren't really encouraging patients to get treatment until noticeable symptoms are present. The Journal of Sleep Medicine talked about the asymptomatic apnea patient. Yeah, asymptomatic, it's such a subjective concept, really, because if we've gained a little weight or if our blood pressure is slightly elevated, for example, we might just assume that it's caused by stress, or some people even chalk it up to not being as young as they used to be. So at what point do symptoms become serious enough that we take notice of them as being symptoms of sleep disorder breathing? Then, if you put yourself in the place of someone who's already suffering from noticeable symptoms of sleep disorder breathing, you could see why this process could be an intimidating process to embark on, especially being that it's not going to result in any relief from symptoms until months later. While going through the process of getting treatment, the patient is still going to have to continue suffering through symptoms such as high blood pressure, irritability, daytime sleepiness, difficulty staying awake while driving, weight gain, which could lead to diabetes, and the list goes on. At the same time, more aggressive medical intervention may be necessary at that point. For instance, medical action to lower blood pressure or control diabetes may be a more immediate concern. So this is why I think it's an issue that the process is so drawn out. And if the process is going to continue to be drawn out, then why are physicians discouraging patients from getting early treatment? And you might say, well, physicians aren't really discouraging patients from getting early treatment. But really, even the Epworth Sleepiness Scale, which is one of the first forms that a patient has to complete if they're interested in sleep medicine, asks questions like, how often do you fall asleep during the day? And this could make people who aren't falling asleep during the day jump to the conclusion that if they're not falling asleep all the time, then sleep medicine must not really be for them. But the fact that it takes so long to go through the process of getting treatment would logically lead us to believe that sleep medicine should be a proactive thing, as opposed to a let's wait until we're in trouble and then take action thing. Waiting until someone's already sick before providing care, that's sick care. That's not health care. And I know I shouldn't impute motives, but it's hard not to suspect that this is done intentionally so that they can get people right where they want them, which is in a state of poor health where they would have to rely on them. Now, if you enjoyed this video, please give it a thumbs up, and for more health and wellness content, please subscribe to this channel, and thank you so much for your support and for watching this video all the way to the end.